Good morning, everybody, and thank you for joining us for Grand Rounds. It is my absolute pleasure to introduce today's speaker, Dr. Glenn Ramsey. Dr. Ramsey is a professor of pathology at the Feinberg School of Medicine and the medical director for the blood bank at Northwestern Memorial Hospital. His area of interest includes clinical transfusion practices, disaster preparedness, immunohematology, and the application of blood group molecular testing to patient care. Dr. Ramsey, we're very delighted to hear you talk about this. Please ask any questions for the speaker in the chat box, and we will get to them at the end of the session.
Oh, good morning, everyone. Thanks very much for having me. I'm going to share my screen. Well, thanks very much for having me. We appreciate the opportunity to talk to you about blood bank issues for your practice and your patients. You're obviously a very important segment of our work that we do in the blood bank, and it's a great chance to discuss that with you and hopefully bring some information to you that you can use and stimulate some discussion with us. I usually do photos of some of my hikes and walks from around the area here, but I thought I would do some travel photos today from before the pandemic to remind us that there is still a world out there, I guess, we can hopefully get back to. So let's go ahead and start. Thanks very much again for having me. I'm also the program director for the fellowship, and I'm very happy about that. And the director of the patient blood management program at the hospital that we'll mention later on. I do some educational lectures for EMICOR, one of our vendors in the blood bank, as my disclosure. And the objectives are to update current developments in blood components and blood supply and demand, to review recent transfusion trials and guidelines for hematology-oncology patients, and discuss strategies for coping with future blood shortages. So the scope will be to discuss transfusion practices in adult hematology-oncology patients. I have to apologize in advance to our pediatric colleagues. I really don't have time to do pediatric transfusion justice today. Maybe another time we can work on that with Dr. Barreto. I'll talk about mainly red cells and platelets, so I won't include your general consultative activities for other services, which are very important, including plasma and cryoprecipitate for coagulopathies. And I won't include therapies which are more in your bailiwick, which will impact hematopoiesis currently or in the future that could have impacts on our your needs for blood bank products. So we'll talk about the national supply and demand and hematology needs among that. We'll remind you about transfusions not being a benign therapy. Red cell guidelines, platelet guidelines against in the hematology-oncology sphere, and that would lead us into planning for blood shortages in the future. And just a couple slides at the end that I showed to the medical students in my lectures yesterday on some predictions for, or maybe wishful thinking for transfusions in 10 years or so. So we saw a mountain there from the Utah, and this is another little bit mountain showing the red cell transfusions in the United States over a 30-year period. And you can see that the red cells transfused went up from 11 million or so up to maybe almost 15 million over a 20-year period, and it went back down to about 11 million a few years ago. And the point of the recent dots here is that the usage has stopped declining and has leveled off and is now slightly increasing in the relative sphere of things. And so there, and also as these lines are coming together in terms of distribution and transfusion. So there's a more limited reserve that there were compared to what there was in the past. And the same for plasma, platelets, and cryo. This is kind of a complicated slide from their presentation at the blood bank meeting last fall, but I just want to focus on the apheresis platelet lines here. Showing that over the past several years, there's been increasing platelet demand in the United States as well. This breaks out into total blood components distributed like this. So about 60% of the products distributed are red cells. The rest are relatively equally distributed between platelets, plasma, and cryo bags. This just serves to point out that these are cryo. This is expressing cryo in terms of the bags from individual whole blood donations that are then pooled to make pools, of course. But you can see that the amount of cryo that's needed to make the amount of plasma that's needed to make cryo is almost as much as the plasma itself. So it's an interesting perspective. And then the transfusions in this survey from the CDC that's done every couple of years. We don't have hematology-oncology specifically, but this is the label that they use for inpatient medicine, including hematology-oncology. So among that 38% of the red cells. Also, probably most of the outpatient sliver there, not a sliver, but the outpatient wedge of 15% is probably in large part hematology-oncology as well. And you can see the other services here as well. So so surgery doesn't account for as much as you might think in terms of the red cell needs, critical care, of course, and so forth. And then platelet transfusions, similarly, about the same proportion for platelets. And again here, probably most of the platelets are probably going for outpatient hematology-oncology patients. This was a study from, 12 hospitals from 2013 to 16. And this again shows a similar distribution of where the platelets were going in these 12 academic hospitals. But this also shows the percentage of patients in, with these various diagnoses. So 25% of the inpatients getting platelets were cancer patients or patients with blood disease, and over 80% of the outpatients getting platelets were cancer and blood disease patients. And among the diseases per se, they didn't really have a total breakdown for this, but leukemia and MDS account for 39% of the platelets, and lymphoma at 7% of all the platelets. So almost half of the platelets were going to those diagnoses. This shows and I just want to focus on the top, the dotted lines here. This is national data from the Swedish Cancer Register in over a decade's time. And the top line is platelets, and the darker line is red cells. And this shows patients with ALL, AML, myelodysplastic syndrome, and lymphoma over the survivors over a 2 years time. And survivors for these diseases use quite a few products, as you can see, per patient, 25 to 30, 35 to 40 red cells and platelets for these survivors going out 2 years for leukemias, myelodysplastic syndrome, and not so much for lymphoma patients. But and this is a slide from City of Hope showing their transfusions in a large adult allogeneic service. Almost all their patients get red cells and platelets in the first month after the transplant, a median of 3 units of red cells and 6 units of platelets. And then the patients who need transfusions in the next 2 months, 45% still need red cells. Over a quarter still need platelets, and the median numbers for those patients getting products is similar. So again, as we know, a lot of products go to patients in your services. And this is interesting because it shows the different types of transplants. This is a graph showing the time to no transfusions in the next 60 days. So transfusion independence, pretty stringent definition, but the match-related, about, I've drawn the 50% line here. So 50% of the match-related patients have completed their red cells in about 2 weeks. Match unrelated going out about 3 to 4 weeks. Haploidenticals go out over a month, and for 50% of them. And cord transplant patients are still getting transplants out to over 2 months after transfusions out over 2 months after transplant, 50% of the time. And the platelets are similar. This is the time to no transfusions in the next 7 days, so a little bit less stringent definition, but about 10 days for the related and unrelated transplants. Again, haploidentical, and cords, as we know, have a more extended course for needing transfusions. What about CAR T patients? I was curious about this for this presentation, but I really couldn't find much about it. It'd be interesting to know what the overall impact of this technology will be going forward. These are patient populations that you know better than I have refractory disease and a poor prognosis. So what will be the overall balance in terms of the product's needs for these patients, with or without these therapies? And I couldn't really find anything in Medline searches about this, but maybe with more time there were transfusion data embedded in some of the CAR T reports that would be interesting to dig up and talk about in the future if there are. This shows our hospital's transfusions over the past number of years, and it's fairly parallel to the national curves I showed before. going down from the 2010, 2011 or so period down to 2017, 2018, and then creeping back up again in the past 4 or 5 years. So we use over 24,000 red cells, over almost 15,000 platelets, 6,000 plasmas, and 2,300 cryopools each year. So quite a number of products, quite a workload for our staff, I might add too. These are some patient blood management measures, some of which were listed by Dr. Carabini in an article that she did about our plasma needs and Kcentra a few years ago, but I've extended the list here a little bit. So you can see that we have quite a few measures that we've done over the years. This is some of them anyway, for trying to reduce or manage transfusion needs. And in more recent years, this includes the introduction of viscoelastic testing in trauma and cardiac surgery patients. We're very proud that due to a lot of hard work from our blood management coordinator, Tricia Boucher, who's on the call, we received certification from the Joint Commission, ABB, for our blood management program, hospital-wide, which we were only the 10th facility in the U.S. to receive this certification. So it's very, very stringent, and we're very appreciative of that. And also this coming year, we hope to introduce transfusion decision support in the EPIC healthcare system to help physicians and clinicians with their transfusion orders. Our outpatient transfusion percentages are shown here over, like as the national curve. We're a little bit more than that, for almost 23% of our platelets are going to outpatients, 13% of our red cells. It's a very minimal amount for the other products, but a very important and probably growing number of our transfusions going to outpatients. And as I said, most of these are probably your patients. So we'll talk about, why should we, worry about transfusions? And as you know, these are not benign therapies, and we'll just talk about a little bit of the yin and the yang of transfusions. They're very important for our patients, but they're also, in some cases, have adverse effects. We talk about, we teach about transfusion and transmitted infections. What are the recalls for risk of infection, transfusion reactions, serious reactions, HLA immunization, and the costs of the blood products. So just where we are with transfusion transmitted infections, we're in a pretty good place for hepatitis and HIV. Less than 1 in 2 million units are now estimated to be potentially transmitting, and other tests are being done on the blood supply for these other agents, as you can see. Bacterial sepsis from platelets is still a continuing concern. About 1 in 100,000 units are reported back to the blood suppliers with bacterial sepsis, and there's been recent FDA-required mitigations, which I'll come back to a little bit more in terms of enhanced cultures or pathogen reduction treatment to treat platelets. And the PRT process inactivates donor white cells as well, so that we don't need to irradiate those products, which is good. But there's always continuing vigilance for emerging infections. There was a recent report a few weeks ago of a surprising Babesia infection, a sickle cell patient who had received and the donor that's implicated appears to be from a non-endemic area in Ohio, for example. And we had an arbovirus encephalitis case, a very serious outcome in this patient a couple of years ago, which was investigated by the CDC and quite a few collaborators here, including the blood bank personnel and pathologists around our system. And this was a very unusual infection called Cache Valley virus, which is there's only a handful of human cases that's ever been reported. And this patient was investigated really because she got a kidney transplant. I don't think anybody would have thought of her encephalitis as being transfusion transmitted, but because they were investigating whether this could have been an organ transplant infection, the CDC got involved and investigated the organ donor, the other recipients, all the other products that had been given to this patient and their donors. And a donor was found that had antibody to this virus, and that plasma had gone to another patient who also had developed antibody to this virus. So it's pretty probable that this was transmitted by red cell exchange, red cell pre-transplant for this sickle cell patient. And this led to a very serious outcome in this patient who's now needs long-term care for her neurological complications. Our transfusion reactions over the past 3 years, you can see we have it's about 0.3% of our transfusions go out, that go out come back as with a report of a transfusion reaction, including a few serious reactions, as you can see here. A couple of cases of trolley over the 3-year time. Other cases that were investigated but turned out to be circulatory overload, and a couple of acute hemolytic transfusion reactions and several delayed reactions and so forth. The FDA collects reports of fatal transfusion reactions, and this is the most recent breakdown from the last 5 years of reports. So TACO and trolley being the most common causes of fatal transfusion reactions reported to the FDA, but the microbial contamination, hemolytic reactions you can see as well. And what about the cost? It's we always get asked about how much this is just how much the hospitals pay for the blood products in the survey from the CDC. There are no other hospital costs included here, including the testing, transfusions, adverse effects, et cetera. But the average payment for red cells is about $215 in this survey a few years ago. Pathogen-reduced platelets at that time were $610. It's a little bit higher now. Plasma, $53, and cryobag. The cryobag times 5 was about $275, which didn't include the pooling price. So just to give you an idea of the cost of the products. And if you break this down in terms of the total national cost of the products, what I want to point out here is we saw the distribution numbers here on the left, but the cost of the platelet products is quite a bit much more per unit. So over a third of the cost of products is in platelets. And this overall we calculate to be about 0.1% of all US healthcare costs. So our system blood budget this is one of the largest lab line items in our budget. It's running now about $2 million a month for the whole system. All right, so with all that as kind of introduction, we can talk about red cell guidelines a little bit. And I tried to round up information that's, as I said, specifically for hematology-oncology patients. And this is an area where we need more information compared to some of the other areas. So before I start with that, I just wanted to point out a recent observation that we kind of expected the expected response per unit on average size patient is 1 gram per deciliter of hemoglobin. But in a recent study from the REDS2 multi-center collaborations by my colleague Matt Carafin and colleagues, the average increment in hematology-oncology patients was actually 0.6 to 0.8 grams per deciliter. So it wasn't clear why this was, except maybe some of the patients have some splenic sequestration. But this is just an interesting observation. But if we talk about guidelines now, so we start with our guidelines, the Transfusion Committee guidelines at NMH. We try to make these fairly simple for everyone to keep track of. So red cells less than 7 grams in asymptomatic stable patients, less than 8 grams in orthopedic cardiac surgery, and this includes stem cell transplants and exchange transfusions and hypertransfusions for hemoglobinopathies separate. Platelets, just the basic here, platelet count less than 10,000 prophylactic transfusions, platelet counts less than 20,000 for central venous catheter replacement, less than 50,000 with bleeding or invasive procedure, less than 100,000 in central nervous system bleeding or procedure, and then platelet dysfunction not correctable by medications and bleeding and invasive procedure. Just to mention that we have a blood bank page in the NMI. You can, if you click enough through NMI, NMH departments, and you'll see a blood bank department. And then on that page, we have a number of pages, sub-pages, including a policy page, some fact sheets, some key references. So it's probably a little known resource for information on transfusion if you're looking for a little bit of background. So what about guidelines? So the Association for the Advancement of Blood and Biotherapies, formerly the American Association of Blood Banks, and then ABB, so the name has changed, but ABB, let's call it. And this was a large collaboration that I was involved in with several years ago on the committee. So they came up with basically hemoglobin less than 7 grams for stable hospitalized patients, as we see, it's widely used, less than 8 grams for prior cardiovascular disease, cardiac and orthopedic surgeries. And they said these recommendations do not apply to severe thrombocytopenia with patients undergoing hematology-oncology treatment and risk of bleeding. and chronic transfusion-dependent anemia. So they didn't really feel that there was enough data to make recommendations in those areas. This is a little bit of a theme going forward here. So this is the ASCO-ASH guideline for erythropoiesis stimulating agents, which is relevant to our topic here. So ESAs when patients are getting non-curative chemotherapy and their hemoglobin is less than 10 grams, although red cell transfusions is also an option, and lower risk myelodysplastic syndromes and with low EPO levels. And of course, these patients would need to be on iron, but only enough ESA to avoid transfusion if there's not a response to stop in 6 to 8 weeks. But this could be an option for some patients, just to mention as well. The Red Cross practice guidelines are available as a mobile app if you're interested in that. You can search for transfusion practice guidelines and download there. It's a very succinct, well-vetted resource that's pretty up to date and has indications, adverse effects, and special needs. But again, in this publication, anemia and chemotherapy, not enough data for a heat threshold recommendation. And there's been meta-analyses of red cell transfusion criteria studies in HEMONC patients, and the conclusion has been insufficient data for recommending hemoglobin thresholds in your patients. And so just before we go on to what data there is, just to mention about hemoglobinopathies, and again, this is a much broader topic than we have time for, but transfusion-dependent beta thalassemia, there was a very nice review a couple of years ago in the New England Journal recommending transfusions when the hemoglobins were less than 9 to 10.5 to ameliorate ineffective erythropoiesis. And there's extensive guidelines from ASH on sickle cell disease, including a transfusion document. And just to mention that transfusion in those patients, as you know, should be matched for antigens CE and K to reduce red cell antibodies. And in some cases, precise matching requires Rh genotyping to identify partial C variants, a topic we could explore another time. So we do have some patients here on, as you know, on sickle cell red cell exchange. This is another small part of our, not so small part of our support services. So there are about 15 patients on chronic red cell exchanges here. 3 of them came over from Lurie Children's last year. 5 of these patients have red cell alloantibodies to work around, and all are getting CE and or K matched red cells according to guidelines. So we gave over 500 highly selected red cell units last year to these patients alone. And thanks to Tricia Boucher, who's on the presentation here for the numbers on that. And speaking of patient blood management, just in terms of how does this apply to hematology-oncology patients, the raw definition, which is sometimes thought of in terms of perioperative settings, are to maintain the hemoglobin, optimize hemostasis, minimize blood loss, and improve patient outcomes. And the principles are fairly similar, as summarized in this editorial a few years ago. So if these principles are applied to patient blood management in stem cell transplants, the Mayo Clinic had a publication a few years ago about their efforts to try to address transfusions in their transplant population. This involved putting out guidelines, educating their clinicians, a lot of data analysis, electronic decision support, and this system that we're planning for NMH is a Mayo-like system. And advocating red cells hemoglobin transfusion at less than 7 for stable non-bleeding stage. So this is basically the general guideline for everybody they were applying to stem cell transplant patients, and platelet counts less than 10 or less than 20 if there was anticoagulation or increased platelet turnover. And they defaulted their ordering system to single unit ordering. And they looked at how this came out. So they had over 350 patients pre and post, so it's kind of before and after study. Most of them are autologous transplants, as you can see. So, after they instituted this PBM program, only 4% of their patients were getting transfusions at over 8 grams, and the mean red cell units went down a unit or so for each patient. And the platelet, likewise, the platelet usage went down from 4.7 to 4 units per patient, and there were no differences in major outcomes in the process of reducing their transfusions. And in Perth, Australia, a little bit farther away, but they had a little bit more success a few years ago in their report, which includes acute leukemia as well as stem cell transplant patients. Their average red cell usage went down from 8 to 6.8 grams. Their average pre-transfusion hemoglobin, went down from 8 to 6.8, and the line there shows their percentage of single unit transfusions went from 35 to almost 70% on the right-hand side. And their mean number of red cells and platelets went down from 6 to 4 for platelets and 6 to 4 for red cells by applying these similar principles with no changes in major outcomes or serious bleeding. So I've tried to round up here a number of studies in one slide. It's pretty busy, but I just want to highlight a few things. So this is 8 observational studies, just trying to look at outcomes of transfusion practice changes in hematology-oncology settings. Several of these are before and after studies of instituting changes, and some of them are even just changing from 2 units to 1 unit at a time with the same hemoglobin threshold. As you can see, and then a few others were at the bottom were changing the hemoglobin threshold with the 2 unit to 1 unit change. So these are 3 U.S. studies and 5 European studies. 5 of them were, as I said, going from 2 to 1 unit at a time with the same hemoglobin goal, and 3 of them were trying to lower the hemoglobin goal. So there were less red cells needed in 5 of these 8 studies, including the ones that just went from 2 units to 1 unit. And in terms of bleeding, the right-hand curve, both studies that looked at bleeding found there was no increase in bleeding when they changed their practices. And there are a few randomized controlled trials. This is what the meta-analyses are getting at. There's really not much data on this so far. A couple of small pilot studies randomizing to different to liberal versus conservative thresholds, showing less units transfused and no changes in bleeding. And then the largest study from last year in Canada, from a couple of years in Canada, of 300 stem cell patients randomized to 9 versus 7, showed a reduction in red cells from 5 to 3 units per patient. And their main outcome was quality of life, which we'll talk about a little bit more here. And the quality of life scores were non-inferior and actually minimally better in the 7-gram group. There are no differences in major outcomes, including bleeding, and there was the percent that got no red cells went from 14% to 47%. And there was a commentary about this that was pointed out that this series of patients seemed to have fairly low comorbidities, and they were fairly fit patients. So there is that. So we're looking for more data like this from other centers or from other studies to try to address this a little bit more. So this brings us to outpatients, and I mentioned how the outpatient transfusions, as you know, are growing quite a bit, and I think this is probably going to continue to grow. This is just a summary of several studies that are starting to look at outpatients, and these are studies that are looking at quality of life surveys and exercise tolerance. And one of the editorials pointed out that this was study what matters to patients, and maybe which is a little different perspective than what we normally see in clinical trials looking at clinical outcomes. So the first study showed that after 1 or 2 units, they tried to look at exercise tolerance. They found a slightly better 6-minute walk score and a fatigue score, and the better walk score was more likely when the hemoglobin was greater than 8. There was a survey of MDS outpatients, or a pilot study comparing hemoglobin less than 8 to hemoglobin less than 10.5. And there were several quality of life measures that were better at the higher threshold. And there was a patient survey asking the patients what they knew about their hemoglobin thresholds and what they preferred. And the patients said that at least in the survey, 27% were aiming for less than 7 grams, and 57% were aiming for less than 8 grams. And a fourth of these patients preferred a higher hemoglobin than what they were getting. So this is a somewhat new perspective, and it's important to. And I just wanted to point out that there's really not much data on outpatient transfusions from the standpoint of outcomes and what their threshold should be. We'll come back to this with platelets, but this is an area that really needs more information in terms of what should our criteria be for outpatients as opposed to inpatients in the hospital setting. So we'll talk about platelets a little bit now as well. Let's see, check my time here. Yeah, okay. So just a word about platelet unit contents and path reduction treatment. And this is a trend or a development that I wanted to mention. The FDA requires the number is the exact number isn't important for you, but I just want we just wanted to point this out that the FDA requires 3 times 10 to the 11th platelets per each unit or pooled platelet dose, and low content units must be labeled as such. So it's been pointed out that all other countries have lower requirements, mostly 2.5, ranging down to 2.0 for some products. There was a commentary a few years ago to consider lowering the U.S. requirement to 2.5. Now there was a little bit of a conflict here because one of the main authors was an employee of one of the companies the company that manufactures the path reduction technology, but this is in the context of the growing use of pathogen reduction treatment for platelets, and these products are more likely to have low content platelets. Versity has said that our main supplier has said that up to 20% of their PRT platelets may become low content in the future. And our platelet inventory currently is about 60% PRT, 40% cultured. So, and this is just an old slide I had from that's actually summarizing the data from a review that we wrote a few years ago. But just focus on the top line. I've grayed out the rest of it. But this is the process that's used in the U.S. for treating platelets, and this is in the clinical trials comparing the recoveries, the lifespan, the randomized, and the CCIs to untreated products. And so these products have about 80 to 85% of the untreated outcomes with regard to recoveries, with regard to lifespan, and with regard to one hour CCIs. And this is CCI is of course correcting for the count in the unit. So the platelets themselves don't survive quite as long, and there's a tendency to have less platelets in these products. So as we go forward, we'll see a little bit more of that coming through probably in our practices. But with regard to guidelines, again, I've compared a number of guidelines here. 3 guidelines mainly to show these different levels. So less than 10,000 per microliter is used fairly uniformly as a prophylactic guideline. It's interesting that the Circular of Information last year used a number of 5 to 10, which may give us a little bit more wiggle room with regard to shortages, but most people use less than 10 or recommend prophylaxis with risk from bleeding 10 to 20 or higher, quote unquote. Prophylactic transfusions in autologous stem cell transplants. Now, we haven't talked about this too much with the transfusion committee yet, but maybe in the future, in the next revision, we might come back to this. So a couple of these guidelines are now calling for waiting for giving platelets until the patient has signs of bleeding, instead of automatically giving them products at less than 10. So this is something we could talk more about. Central venous catheter insertion, less than 20, lumbar puncture, 40 to 50, percutaneous liver biopsy, 50, major surgery, 50, 40 to 50, neurosurgery, less than 100, non-severe bleeding, 30, and severe bleeding, 50. So these are all pretty familiar, mostly pretty familiar numbers I'm hopeful for what we use. And these guidelines were all compared in this transfusion reference down below. And other diagnoses were reviewed by Yuan and colleagues in the article that's referred at the bottom. So what about how we do with regard to the appropriateness? There was an audit in Ontario looking at almost 2,000 orders for platelets, and they had detailed appropriateness criteria that they used to audit the orders in retrospect. And overall, almost 60% of the adult orders were appropriate. I'm happy to say that the highest ranked specialties were oncology and hematology, 76 and 63% being appropriate, which was 25% of all the orders, but there's still some room for improvement. And over half the inappropriate orders for prophylactic transfusions over 10,000. One of the more significant studies last year, at least according to Transfusion Medicine Review, was a study of prophylactic tranexamic acid in thrombocytopenia patients with chemotherapy or immunotherapy or stem cell transplants for hematologic malignancies. And these were patients who were enrolled they were going to have expected platelet counts less than 10,000. They excluded thrombosis history patients and current anticoagulation and APL patients. So they randomized over 300 patients, double-blind fashion, to placebo or tranexamic acid, while their platelets were less than 30,000. And unfortunately, the primary outcome of grade 2 or more bleeding incidence was the same. So the tranexamic acid didn't really work in these patients to prevent bleeding or reduce transfusions or days without bleeding or change thrombosis or bleeding deaths. And there were no subgroups benefits either. There was and in fact, there were more line inclusions in the tranexamic acid patients than the placebo patients. So unfortunately, this is useful in bleeding, but it doesn't seem to be very useful so far in prophylactic treatment, unfortunately. So again, coming back to outpatients, again, 16% of US platelets, 22% of the NMH platelets are going to outpatients. To our knowledge, there have not been any clinical studies that have addressed transfusion criteria in outpatients who are going about their activities of daily living and so forth, that we all are concerned about and think about. There are a few comments in the guidelines, which I've paraphrased here in the ABB guidelines. More liberal prophylactic threshold may be appropriate for reasons of practicality, fewer clinic visits, parenthesis. In the British standards, medium to high dose of platelets for outpatients, which might limit the transfusion frequency, may be considered. In the ASCO cancer guidelines, higher prophylactic threshold may be advisable when platelets may not be available for emergencies, such as outpatients who live at a distance from the center. But so comments, but not really data about whether this is about what the exact outcomes are. There was a practice survey that was published in December from an ABB committee that surveyed the ABB accredited transfusion services. They got a response rate from over 300 labs. Half of them had no formal criteria for outpatient platelets, and among those who did state criteria or clinical practice thresholds, 50% were using less than 10,000 for outpatients, 29% were using less than 20,000, and 14% were using less than 50,000. So at least some practice numbers, but not really, studied, well-studied, well-studied, good studies on this. So home transfusions coming back. This was a headline in the New York Times last month. Your next hospital bed might be at home. In the 80s and 90s, home health agencies were doing home transfusions. This was before I came to Chicago. I'm not sure what was going on here, but in Pittsburgh, there were home health agencies picking up blood products to take out as part of their services. So now this hospital at homes movement, so to speak, is coming back in some areas of the country where physicians and nurses provide a feasible home care for patients that might otherwise be admitted. And there were actually 2 recent reviews of home transfusions. And I'm just raising this as I don't really know of any, we've not really had any questions about this yet, but I just wanted to mention this, possible benefits being patient convenience, less nosocomial exposure going back and forth to the treatment facility. It could be part of palliative care. It may or may not reduce costs. And certainly some concerns to consider, including transport of specimens and blood, patient safety, transfusion reactions, perhaps delayed complications. So this is something to think about. If there's questions or comments, we could talk more about it. And so this all brings us to some comments about blood shortage planning. So in the pandemic-related blood shortages, just to explain a little bit more about this, everyone I think was aware of this. This was exacerbated in the later stages of the pandemic. We had higher overall disease severity levels in our patients coming into the hospital or coming back to the hospital for care after the sort of interlude of the pandemic, and which led to a rising demand for transfusions, as we saw in those national and local numbers. But at the same time, there were challenges of recruiting and collecting blood donors, loss of mobile blood drive venues, staffing shortages in blood centers like every place else. And this led to a severe Group O positive red cell shortage a year ago. So how do we assess the inventory assessment? How do we assess the inventory? We normally like to have at least 3 days worth of normal use for each blood type. And we get typical daily deliveries to equal daily usage. So we keep things balanced, and we can ask for additional units for extra needs. So group O red cells are often involved in shortages. They're used out of proportion to their 45% of the donors and patients that are group O because they're given as emergency uncross-matched units to patients, including massive transfusion protocols. They're given to neonates and some non-O, and one small part of this is some non-O allo stem cell transplant patients are getting group O red cells during their blood type switches. So we express this as days of supply. How many days will inventory last at normal usage rates? Well, this doesn't really work for platelets, but for red cells, this is a common way to express inventory levels, such as the National Blood Center, some of the National Blood Center data from the America's Blood Centers and ABB weekly inventory levels shown here. And again, over 3 days of red cells is desired. This might vary with the distance from the supplier and the stat delivery time. So in you modeling this for contingency or critical levels, these are just just to show you how we would calculate this. So we can break down our annual red cell numbers in terms of the different blood types, and then calculate the daily and then the 2-day, 3-day, 4-day usage in terms of where we would like to be with our inventory, and then assess our shortage level. And this is a format of a report that is sent out to hospital leadership when we're in a shortage in terms of showing where we are with, and these are just mock numbers but where we are, what zone we are with group O red cells, O neg red cells, cryo, platelets, et cetera. So in the shortage last year, we had a number of things that we were doing. We reported some of this in an abstract at the ABB last fall. Strict adherence to hemoglobin threshold guidelines, giving 1 unit at a time for non-bleeding patients, consolidating our inventory. We were doing advanced cross matches and holding units only for antibody patients, reducing our MTP batch from 6 to 4 here, pulling back from group O red cells from remote emergency refrigerators. For large blood user settings, we were asking the liver transplant service to pre-clear liver offers for group O patients. The code aorta emergency aneurysm surgery program here was on hold for a while for other reasons, so that was in our favor a little bit. And we were monitoring, along with the surgical leadership, upcoming OR schedule for large cases. And IDPH would not have permitted us going on trauma bypass because of blood shortage. So that was not an option to stop taking trauma patients. So we also tracked inventory system-wide in our NM system. We did inter-hospital transfers if it was feasible. We lowered the hemoglobin thresholds, as you recall, by 0.5 grams per deciliter, including stem cell patients. Half unit red cell transfusions were given if there was clinical concern for hemoglobins below the normal threshold, and over 70 half units were given during that month. We kept some ABO switch patients on non-O red cells when it was safe to do so during that phase of their transplants. So ultimately, there were no necessary transfusions that were denied, and there was no canceled surgery, and there was no adverse clinical effects reported. So with everybody's, and just to elaborate a little bit more about that, communication was really critical. Obviously, we were sending this inventory chart around. We sent messages to key medical leaders. As you probably recall if you were here, we were putting out banners and alerts on the hospital website, and the blood drives by the suppliers were ramped up in the hospitals. And now we have regular drives every Tuesday and Wednesday over in Prentice from Versity. So, and overall, our clinician colleagues and you all were very helpful in understanding of the need to conserve blood products during this time to get everybody through. If this wasn't an issue with Rh negative red cells, but if Rh negative red cells are low, we would prioritize those for Rh negative women of childbearing age and switch other Rh negative patients to Rh positive red cells in some cases. There's about a 20 to 35% rate of anti-D formation 2 to 6 months after getting transfusions, and a very low rate anti-D rate in liver transplant patients because of immunosuppression. So for platelets, platelets are collected at day 0, sent to the hospitals on day 2, and expire on day 5 to 7. So it's a very delicate balance of having a sufficient supply versus avoiding outdating excess units. We have a rapid inventory turnover, often 2 different deliveries a day. And so the days of inventory, as I mentioned, for red cell assessment doesn't really work very well for platelets. But after the early morning delivery, our stock should be sufficient for the day's needs, at least the first and second shift. And then we get another shipment late in the day as needed. So platelet shortages can develop very quickly due to weather, community illness, long holidays, donor lab testing delays. Something happens to interrupt the constant supply of platelets that this can come up without too much warning. We can temporarily postpone prophylactic transfusions until more units arrive. And as I mentioned, the FDA Circular of Information, which is the blood product to package insert, has mentioned 5 to 10,000 as a potential threshold. We would issue 1 unit per order even for outpatients, and we would monitor outpatient OR schedules for planned needs and recommend perioperative viscoelastic testing to assess platelet needs in the surgical setting. And we can issue half units that might suffice to meet a platelet goal of greater than 50, for example, for an urgent procedure. So there's been a whole lot of post shortage, well, even some of this pre-shortage, but a lot of discussion during the pandemic about shortages and how we can manage this. And these are just some of the more more widely visible references that have come out in recent years about this, including how do I manage long-term blood component shortages, critical conversations on patient blood management, triage tool for rationing blood. They're a little bit more honest in Britain about this, I guess. So we've done some, and also just to elaborate, one of these references had some discussion of hematology, in particular sickle cell exchange transfusions, to try to evaluate patients for whether it would be feasible to do simple transfusions or partial exchanges to change the hemoglobin S percentage goal from 30% to 50% if that could be tolerated, or the fraction of cells remaining to be at least 35% for neurologic indications and 40% for non-neurological indications. So we've done some planning ourselves here. This stimulated a lot of planning to discuss, discussions about what we would do with more severe shortages and how to allocate limited blood resources among competing demands, which are very clinically justified. So we had medical ethics involved, Dr. Neely and her colleagues, the lab and blood bank leadership, hospital leadership. And so we were coming up with a draft plan for what would happen in a future severe or prolonged shortage. And this is one of the tables. This is the red cell for red cells here, looking at contingency phase and crisis phase, trying to reduce the thresholds for transfusion as needed to try to get through, as you can see. And we were sort of in the contingency phase for last year, but this is if we really got down to less than 1 day's supply to try to get through. And then for platelets, this is not quite as much filled in, but we, again, mentioning 1 unit limits, postponing prophylactic transfusions, lowering giving half units in some cases. So, and it also involves adding some criteria for blood ineligibility. This is where medical ethics folks, clinical clinicians input comes in. Patients with very poor prognoses by clinical indices. Daily upper limit for how much large scale users could use based on inventory that would be calculated and notified in advance. And there would be a team of protocol officers in each region to review individual patients if needed, involving an intensivist not involved with the patient, ethics committee member, and senior administrator. So not the blood bank, but we have some outside experts looking at this would have in each NM region for particular questions that come up about individual patients. So I have a couple more slides about, these are the slides that I showed to the medical students yesterday in my lecture to them in terms of what they might be looking for in the next 10 years. So this is my cracked crystal ball, I guess, or maybe a wish list. We'd like to see or hope to see more data on transfusion indications, including, as I've mentioned many times here, outpatient red cell and platelet transfusions. There is as you may have heard in the news or some of your newsletters, there is under long-term development, there is some recent progress with growing red cells in large-scale cell cultures, and the first human trials of really minute quantities being infused are underway. These red cells could be these cell lines could be genetically altered to make rare blood types, which might be one of the first applications for such products. And for platelets, we're in a trial of maybe not so much for hematology patients, but we're in a trial of cold stored platelets, looking in our case, cardiac surgery, platelets are hemostatically activated by cold storage, and these are being looked at for surgical or trauma hemorrhage and these could be stored longer than in our room temperature products. And then freeze-dried platelets for long-term storage are being looked at. There's a phase 1 trial that's recently published about freeze-dried platelets. And in terms of transfusion safety, we hope to get to the point where there's path reduction treatment for red cells also. Then that would be in a situation where all components will be treated now, or potentially treated: red cells, platelets, plasma, cryo, et cetera. We mentioned the red cells being grown in cell culture. There'll be less worry for newly emerging agents, definitely in that environment. And then, finally, better understanding of who is at risk for red cell alloantibodies. If we could figure out who are the patients who are going to make antibodies, we could do extra antigen matching for them. And this would involve more blood group genotyping for donors and patients that we do here for our patients, and the blood centers are doing for their donors. So that concludes my presentation. I just wanted to, there's a few references that I wanted to mention: the transfusion practice guidelines that are online or on a mobile app. There was a discussion at the ASH a few years ago discussing some of these gaps in knowledge of transfusion support. Dr. Yuan's all review of platelet transfusion indications, and Rich Gamma's discussion giving us some advice in the blood bank for consulting with our clinicians about transfusion indications and shortages. I want to thank our blood bank team: Dr. Paul Lindholm, Ricardo Sumagata, Director; Jonathan Pugh, our Operations Coordinator; Tricia Bochet, our Blood Management Coordinator; Laura O'Shaughnessy, our Compliance Coordinator; Miriam Malik, our current Fellow; our blood bank professional staff, who are the real unsung stars. And our fellowship faculty includes Christina Barreto at Lurie Children's Hematology and Blood Bank, and Anna Zachariah in Hematology. And to conclude my travelogue a little bit, there's a Vermeer exhibit that's just opened in Amsterdam, getting a lot of publicity. And as you may know, Vermeer was a painter who only painted about 3 dozen paintings that we have available. And these are my pictures of some of them in the museums that we visited, including in Vienna, which is not, this painting is not in the exhibit. Anyway, those are a little bit different perspective. And then I'm ready for your questions and comments. Thanks very much again for having us, and I really appreciate the chance to visit with you today.
Thank you, Dr. Ramsey. I don't think we have any questions in the chat box, but if anybody has any questions, please go ahead and ask Dr. Ramsey. I don't see any takers for questions, Dr. Ramsey, so that was great. Thank you so much once again for giving us this talk.
Thanks very much.
Just as a reminder, next week's run rounds will be in person, so we hope to see everybody in person next week.
Thanks again. Have a good day.
Thank you.